Welcome back to the Rad Onc Smart Review GYN Cancer Series. Today we're doing something a bit different, a dedicated mock oral session.
Right.
We're going to focus entirely on GYN brachytherapy. It's, a very high-yield topic for boards, and the consequences of getting it wrong are significant.
Absolutely.
So I'll be acting as your examiner and sort of a teacher, walking through different cases, applicators, procedural scripts, planning, and of course troubleshooting.
I'm ready. Let's get into the case material.
Okay. Before we jump into the first case, let's establish our foundation. The North Star, if you will, that has to guide every single definitive cervix case. Can you state the 3 absolute numerical goals for a successful treatment? I'm looking for the target goal, the critical organ at risk caps, and the time constraint.
Okay, so the core objective really is achieving tumor control with dose escalation while, rigorously protecting the normal tissues.
Exactly.
So specifically, our cumulative goal is delivering a high-risk clinical target volume, or HRCTV D90, of greater than 85 gray equivalent dose in 2 gray fractions.
EQD2.
EQD2, right. And that's calculated assuming an alpha-beta ratio of 10 for the tumor. And this dose, it have to be delivered adaptively to meet those OAR caps.
Excellent. And what are those caps? What are the numbers you cannot exceed, also reported in EQD2?
So the key OAR caps, these are calculated in EQD2 using an alpha-beta of 3 for normal tissues.
Yeah.
They are the bladder D2CC less than 90 gray.
Okay.
And then the rectum, sigmoid, and small bowel D2CC all need to be less than 75 gray.
And if you can't meet those?
If you can't meet all 3 of those, we have to adapt our technique. And crucially, there's the time constraint.
Yes.
The total treatment time from the start of external beam all the way to the end of brachytherapy, it has to be less than or equal to 7 to 8 weeks.
Perfect. Let's pause on that for a second. Why is that time constraint so critical? We always focus on the dose, the gray, but why is the clock just as important for these patients?
Well, the time constraint is essential because cervical cancer, and especially squamous cell carcinoma, is known to have a rapid accelerated proliferation rate.
Particularly late in the treatment course, right?
Exactly. Studies, I'm thinking of the big analysis from MD Anderson, have shown that if that overall treatment time goes beyond 8 weeks, there's a measurable and a really significant compromise in local control.
How significant?
It's often quoted as decreasing by about 1% per day of delay beyond that 8-week mark. So minimizing any gaps in treatment and compressing the schedule is a direct way to fight that tumor repopulation and, preserve the chance for a cure.
That's the level of understanding we're looking for. Linking that biological driver repopulation to the logistical constraint of time. Fantastic. Okay, let's apply this to a case. All right, let's jump into the first case. We have a 45-year-old patient. She's been diagnosed with FIGO stage 2B cervical squamous cell carcinoma.
Okay.
She has just completed 45 gray of pelvic external beam radiation therapy, or EDRT, over 5 weeks with weekly cisplatin.
Standard of care.
Standard of care. Today, she's in the operating room for her first brachytherapy fraction. You perform an exam under anesthesia, an EUA, and she's had an excellent clinical response. You find a residual mass of about 2.5 centimeters, and it's confined strictly to the cervix. Her vaginal fornices are pliable, and there's no stenosis or vault narrowing.
So a favorable situation.
Very favorable. So, given this status, what is your cumulative dose goal, your initial choice of applicator, and your standard high-dose rate fractionation schedule for the boost?
Okay. My immediate goal is, of course, that fixed cumulative target that we just talked about. I'm aiming to achieve that HRCTV D90 greater than 85 gray EQD2, while at the same time respecting those OERD 2cc limits of 90 gray for the bladder and 75 gray for the rectum and sigmoid.
And the applicator?
Based on the scenario, the excellent response, the normal vault anatomy, and that central 2.5 centimeter residual, I'd choose an intracavitary HDR brachytherapy approach.
Which specific device?
The standard choice here would be the tandem and ovoids, or perhaps the tandem and ring system. This choice really leverages the steep dose fall-off of brachytherapy to deliver an ablative dose right where the disease is, centrally, using her favorable anatomy.
Okay, and fractionation?
For fractionation, a very common and effective schedule to complement 45 gray of EBRT is 28 gray delivered in 4 fractions.
So 7 grays per fraction.
Exactly. Or some places use 27 to 30 gray over 3 to 4 fractions. We'd deliver these, 1 to 2 times per week, and we'd be carefully tailoring the exact prescription to make sure we hit our coverage goal and respect those OAR constraints fraction by fraction.
That's the correct clinical pathway. And I want to highlight something you did there, which is critical for performance under pressure.
Okay.
You led with the EQD2 biological target and the OAR caps before you quoted a specific fractionation. That shows that you understand the fractionation is just a delivery mechanism, it's adaptable, but that biological dose goal, that's non-negotiable.
Right. The goal is the goal.
Precisely. Now, let's get into the physics that makes this all work. Give me a crisp, complete explanation of why the inverse square law is the core principle driving the huge therapeutic ratio we see in GYN brachytherapy.
The inverse square law is absolutely fundamental. It dictates that the dose from a point source falls off dramatically, specifically with the square of the distance from that source.
And in brachytherapy.
In brachytherapy, this lets us put the sources right next to or even inside the HRCTV, so we can deliver a really ablative, localized dose. We're talking hundreds of grays in physical dose right near the source, while at the same time creating this incredibly steep dose gradient.
And that gradient is what saves the normal tissues.
Exactly. That gradient ensures that the bladder and rectum, which are only a few centimeters away, get a much, much lower dose. That maximizes the therapeutic ratio, which is, the defining advantage of brachytherapy.
That's the textbook answer. Let's make it even more visual. If that high-dose volume right around the ovoids is getting, say, 7 grays per fraction, what percentage dose drop are we talking about for the rectum and bladder just by being displaced 2 or 3 centimeters away?
The fall-off is profound. If you normalize the source strength at the tumor surface, by the time that dose reaches the rectum, maybe 2 to 4 centimeters away, it could drop by a factor of 4 to 9.
So you're saying the rectum might only get...
It might only receive between, say, 25% and maybe as low as 12% of the dose that the immediate tumor surface is getting. It's why even a tiny 1 centimeter displacement from packing has such a monumental effect on OAR sparing.
Fantastic. Understanding that gradient is absolutely key to understanding the next phase, which is the procedure itself. So if I asked you to recite a polished 10-step script for a tandem and ovoids insertion, what are those 10 non-negotiable steps? And pay special attention to the 2 major safety lines.
Okay, I'll follow a 10-step structured procedural script for the tandem and ovoids insertion.
Go ahead.
Step 1. Exam under anesthesia and mapping. I'd start with a thorough bimanual and rectovaginal exam. This confirms the current extent of the disease, maps the uterine position anteversion, retroversion, and makes sure there's no new stiffness or sidewall involvement.
Good. Step 2.
Step 2. Patient prep and positioning. Patient is placed in dorsal lithotomy. We insert a Foley catheter to decompress the bladder and clearly delineate its location on imaging. Then a rigorous sterile prep and prophylactic antibiotics per our protocol.
Okay.
Step 3. Cervix exposure and grasp. I expose the cervix with a speculum, then securely grasp the anterior lip with a tenaculum. This lets me apply gentle, consistent downward traction to straighten out the uterocervical angle.
And after that?
Step 4. Uterine sounding. I'd sound the uterus carefully under that gentle traction to figure out the depth and angle of the uterine cavity. And this is my critical safety line 1. If I feel any sudden loss of resistance, any give, I stop immediately.
What do you do?
I pull back a little and verify the depth and angle with real-time ultrasound guidance. I have to rule out a perforation before I go any further.
Crucial. Step 5.
Step 5. Dilation. I would sequentially dilate the cervix with Hagar dilators, just enough to comfortably accommodate the tandem.
Okay.
Step 6. Tandem insertion. I'd insert the tandem smoothly into the uterine cavity, making sure it reaches the fundus, confirming the angle and length based on what I found during sounding in the EUA.
And the ovoids.
Step 7. Ovoid seating. I select and seat the largest size ovoids, or ring, that fits comfortably and snugly in the lateral fornices. This is key for maximizing the lateral dose coverage of the HRCTV. Step 8. Packing. This is huge. I pack the vagina generously and very deliberately, anteriorly, posteriorly, laterally with gauze. This does 2 things. It stabilizes the whole applicator setup, and most importantly, it displaces the bladder and rectum away from that high-dose zone. This is my safety line 2 for minimizing OAR dose, especially for the rectum.
Excellent. Nearly there.
Step 9. Securement and final check. I secure the whole assembly firmly, gently remove the speculum, and then do one final bimanual and rectal check to confirm everything is stable and the rectal displacement is adequate.
And the final step.
Step 10. Imaging and planning. We proceed to imaging. MRI is preferred for the soft tissue contrast, but a CT is acceptable. I'd reconstruct the channels, meticulously contour the HRCTV, the IRCTV, and all the OARs, and then optimize the plan to hit that D90 goal while staying within our OAR limits.
That's a robust script. Let's underscore one element from it, the Foley catheter. You mentioned it helps delineate the bladder, but clinically, what's a specific, actionable piece of information you can get from the Foley that might influence your packing?
That's a great point. The Foley is vital for a couple of reasons. First, yes, it empties the bladder, which standardizes the OAR volume across fractions. But also, and this is critical, if I'm worried about my anterior packing, I can slightly inflate the balloon with a bit of contrast fluid, maybe 7 to 10 cc's. This can physically push the bladder base a little more superiorly and anteriorly away from the anterior ovoid sources. It's a subtle but really useful lever for reducing that bladder D2cc if it's tight.
Good. Now for a clinical twist.
Okay.
You inserted that first fraction successfully. But now, at the second insertion, the patient's vault anatomy has changed. There's moderate vaginal stenosis, probably from early radiation effects, and your standard ovoids just won't seat properly. The tandem is in, but the ovoids are gapping or pushing on the rectum.
Yeah.
How do you adapt right now while still preserving that necessary lateral coverage?
Okay, so if the standard ovoids can't seat, my approach would be a stepwise escalation, mechanical and technical.
What's your first attempt?
My first attempt at adaptation would be to try a less bulky applicator. I'd immediately try to switch to a tandem and ring applicator if I wasn't already using one. The ring often has a smoother, more streamlined profile and can sometimes slide into a stenotic vault more easily than the ovoids.
And if that still doesn't work?
If the ring still results in bad seating, or if my lateral coverage is still compromised, then I have to move to my second level of escalation. This requires a change in philosophy. I'd use a tandem and cylinder applicator to provide central stability.
But the cylinder alone won't give you lateral throw.
Exactly. So I would critically augment this with selective interstitial needles. I would explicitly state that I'm now adopting a hybrid intercavitary and interstitial approach.
And what does that achieve?
The cylinder gives me dose to the central tumor, but the strategically placed needles inserted into the parametrium or residual tumor, they restore that crucial lateral dose coverage that the failing intercavitary part couldn't achieve. This hybrid system is the necessary response to adapt to bad anatomy while still hitting that HRCTV D90 goal.
That phrase, hybrid intracavitary and interstitial, is exactly what an examiner needs to hear. It instantly shows you're ready to manage complex geometry. When you add those needles for stenosis, how do you decide how many to place and where do you aim them?
The needle placement is driven entirely by the contouring of the residual HRCTV and the OARS. Since the stenosis is limiting my lateral dose, the needles have to go laterally and maybe a bit interiorly or posteriorly to cover those cold spots that show up on the plan.
So it's very targeted.
Very. If the residual disease is just on one side, I might only need 3 or 4 needles on that side. The key is to run the needles parallel to the rectum and bladder to avoid piercing them, placing the sources along the edge of the tumor to, fill the gap that the stenosis created.
Excellent. Let's switch gears completely. We'll move to the endometrium.
Okay.
We have a 65-year-old patient, status post a total hysterectomy, and bilateral salpingo-oophorectomy for endometrial cancer.
Got it.
Her pathology comes back. Grade 2, endometrioid adenocarcinoma with some high-risk features, 60% myoinvasion and substantial lymphovascular space invasion, or LVSI. Final stage is pathologic T1BN0. She's referred to you for adjuvant vaginal cuff brachytherapy. Outline your complete cylinder plan. I want the dose prescription rationale and the 7 essential procedural steps.
Okay. My recommendation is adjuvant vaginal brachytherapy delivered with a cylinder. The treatment is targeted only to the vaginal cuff, usually the proximal 3 to 4 centimeters, since that's where, 80% of isolated local recurrences happen.
And is she a good candidate?
Absolutely. Given her risk factors, the high-grade features, deep myoinvasion, LVSI, she's clearly in the high intermediate risk group. This justifies adjuvant radiation to reduce her local recurrence risk from about 12% down to around 3%.
Okay. Dose and fractionation.
A standard HDR plan could be 21 Gray in 3 weekly fractions or 30 Gray in 5 fractions. And the dose is prescribed to a crucial depth of 5 millimeters from the cylinder surface.
Good. Now walk me through the 7 key procedural steps.
Okay. 7 key steps. Step 1, cuff verification. I have to confirm the vaginal cuff is well healed, no dehiscence, no infection, no active bleeding before we start.
Makes sense.
Step 2, cylinder selection. I'll select the largest diameter cylinder that can sit completely flush against the apex without causing too much tension. Using the largest diameter is vital
Why?
because it pushes the 200% isodose surface further away from the mucosa, which means a lower mucosal surface dose and less risk of late stenosis or atrophy.
Good. Keep going.
Step 3, insertion and verification. I'd insert the cylinder and verify I have stable, full midline contact at the cuff, no air gaps.
Right.
Step 4, planning imaging. This is non-negotiable. On the very first fraction, I have to get a CT scan of the pelvis. This confirms the positioning, checks for any tilt or gapping at the apex, and lets me properly assess the bladder and rectum proximity.
Okay, 3 more.
Step 5, prescription depth. I ensure the dose is prescribed to exactly 5 millimeters depth from the cylinder surface. This is chosen to cover the perivaginal lymphatics and potential microscopic disease.
Right.
Step 6, delivery. I deliver the treatment after all the QA checks are done.
And finally.
Step 7, stenosis mitigation. After the radiation is complete, I'd provide thorough counseling on starting vaginal dilator use, usually 2 to 4 weeks after treatment. This is the main way we actively mitigate long-term stenosis.
That 5 millimeter depth is a critical detail. What's the danger if you just prescribe to the cylinder surface?
If we prescribed only to the surface, the depth dose would fall off way too quickly. You'd likely underdose the deeper tissue where microscopic disease might be.
And the surface itself.
The surface dose would be incredibly high, likely exceeding the tolerance of the vaginal mucosa and leading to much more severe acute and late toxicity, mostly painful atrophy, adhesions, and really aggressive stenosis. That 5 millimeter prescription is the accepted balance between coverage and tolerance.
Excellent. The takeaway for the cuff script are those 4 high-yield points you made. Largest cylinder that fits, a CT on fraction 1 to check for tilt, prescribed to 5 millimeters depth, and keep that 200% isodose line inside the cylinder.
Got it.
Now for the twist. Same 65-year-old patient, but her pathology shows not just high-risk features, but a focal positive mucosal margin right at the vaginal cuff. How does that finding fundamentally change your plan, and which applicator do you prefer now for the brachytherapy?
Okay, a focal positive margin that completely changes the intent. This is no longer an adjuvant prophylactic case. It's now a therapeutic one.
So what does that mean for treatment?
It means simple vaginal cylinder brachytherapy alone is now inadequate. It just doesn't address the high potential for perivaginal disease spread or the increased risk of regional nodal failure, which is now definitely not zero.
So what's the new plan?
I would escalate the management to include pelvic external beam radiation therapy. I'd prescribe about 45 to 50.4 gray to the pelvic fields, making sure to cover the perivaginal tissues and the nodal basins, the iliacs, and obturators.
And then the brachytherapy.
I would follow the EBRT with a brachytherapy boost. And for this boost, I would strongly prefer a multi-channel cylinder.
Why multi-channel?
The multi-channel capability lets us do precise planning optimization. We can differentially sculpt a higher, more conformal dose specifically towards the part of the cuff that had the positive margin while still respecting the OAR constraints. My target EQD2 would be roughly 65 to 75 gray to that involved area.
Perfect.
Yeah.
That shows you understand how a single pathology finding can shift the entire treatment paradigm. Okay, let's go back to our initial cervix patient, FIGO stage 2B.
Okay.
We gave her the same 45 gray of EBRT and cisplatin. But this time she has a poor clinical response when she comes for her first brachytherapy. On EUA, you find a 4.5 centimeter asymmetric residual mass with clear right parametrial extension all the way to the pelvic sidewall.
Oh, wow.
You assess that a standard intracavitary applicator, like tandem and ovoids, cannot possibly cover this bulk and asymmetry without severely violating OAR limits, especially the right bladder wall or sigmoid.
Right.
What is your definitive recommendation for brachytherapy here, and what's your rationale?
Given the bulky asymmetric disease and that parametrial extension to the sidewall, intracavitary is off the table. My recommendation is to proceed with image-guided interstitial brachytherapy using a perineal template, or, if a central tandem can still be placed, a hybrid intracavitary and interstitial approach.
And what are the specific indications that drive that decision?
The rationale hinges on 3 critical indications for interstitial brachy. 1, bulky residual disease. 4.5 centimeters is just too large for the high-dose volume of an intracavitary applicator to fully cover. 2, asymmetric or irregular geometry. That extension to the sidewall means the concentric dose of ovoids or a ring will inevitably create cold spots laterally.
And 3.
And 3, OAR limited intracavitary coverage. The tumor is right up against the bladder and sigmoid. Dose escalation is impossible without using interstitial needles to physically pull the dose away from those critical structures.
So interstitial is superior here because...
It's superior because the catheters enable precise conformal loading. We can actually shape the high-dose volume to match the irregular tutor, achieving that HRCTV D90 goal while aggressively maintaining our OAR limits.
You cited the 4.5 centimeter size as too bulky. Is there a formal metric for when intracavitary methods just become inadequate?
Yeah, the commonly accepted threshold for when the HRCTV becomes really tough to cover with intracavitary alone is when the width or height gets over about 5 centimeters.
And why is that?
At that size, the target extends too far laterally beyond the maximum dose delivery radius of the ovoids. The dose falls off so steeply that you just can't get adequate dose to the perimeter without overdosing the center. So if the residual is 4 centimeters or bigger, most centers will think about an immediate move to a hybrid approach.
Good. Now let's talk procedure. Outline the 5 key steps for placing an interstitial template implant. I want you to focus specifically on the imaging used during insertion versus the imaging for planning.
Okay, a 5-step procedural outline for an interstitial implant.
Go ahead.
Step 1, positioning an EUA. I'd position the patient in dorsal lithotomy, place a Foley, and do a final EUA. This exam has to include meticulous mapping of the residual disease, maybe even marking the lateral and superior limits with sutures to guide the needles.
Okay.
Step 2, template securement and central device. I'd securely fasten the perineal template like a SIAD or MUPIT to the perineum, and if it's possible, I'd insert a central tandem or cylinder to act as a fixed geometrical reference.
And then the critical part.
Step 3, needle placement and real-time guidance. This is the most crucial step. I'd place the interstitial needles through the template grid to encompass the cervix, the tumor, and the parametria. And all of this is done under real-time transrectal ultrasound guidance.
Why is the TRUS so important here?
The TRUS is essential for confirming where the catheter tips are relative to the tumor margins, and more importantly, for verifying that the needles are placed just lateral to the rectal and bladder walls. It's all about ensuring OAR integrity in real time.
And after the needles are in?
Step 4, planning imaging. Once all the needles are placed and secured, we get our definitive planning images. This means a CT or an MRI with the whole implant in situ. MRI is much preferred because it gives you superior visualization of the HRCTV and OARs for 3D planning.
And the final step.
Step 5, delivery and removal. We deliver the HDR treatment, often using an accelerated schedule like twice a day to manage the time constraint. Then finally, we remove the entire implant, making sure the patient has appropriate analgesia and antibiotics.
What's the single biggest technical challenge when you're using that TRUS guidance, especially with bulky fibrotic residual disease?
The biggest challenge is often just telling the difference between the residual tumor and the post-EBRT fibrosis and edema. TRUS relies on echogenicity, and fibrosis can make everything look uniform. It can be really hard to see the precise border between the tumor and the rectal wall, for example.
So the TRUS is really for?
It's mainly for real-time safety verifying the needle position relative to the OAR. The definitive planning has to be left to the MRI, which gives us the much better tumor contour.
Right. So the critical imaging trio you have to mention is real-time transrectal ultrasound for safety during insertion, MRI or CT for the 3D planning, and explicit careful contouring of the HRCTV and IRCTV to define the target.
Exactly.
Okay, let's move to plan evaluation. You're asked to review a finished tandem and ring plan. Prescription is 7 gray per fraction. Here's the DVH data for this one fraction. HRCTV D90 is 7.1 gray. Bladder D2CC is 6.5 gray. Rectum D2CC is 4.8 gray. And sigmoid D2CC is 4.2 gray. Using the structured 3-part triad, read this plan for acceptability.
Okay, I'll evaluate using the triad: coverage, constraints, and conformality.
Let's start with coverage.
First, coverage. The HRCTV D90 is 7.1 gray. That's 101.4% of the 7 gray prescription. So it exceeds the prescription, it's on target, and it's acceptable. Good coverage.
Good. Next, constraints.
Second, constraints. The OARD2CC values. Bladder is 6.5 gray, rectum is 4.8, sigmoid is 4.2. All of these are well below the typical perfraction tolerance, and they project to an acceptable cumulative EQD2. The constraints are met.
And finally, conformality.
Third, conformality. Given the really strong target coverage combined with the low OAR doses, the plan is highly likely to be conformal. I would, of course, visually confirm this by reviewing the isodose lines on the axial and sagittal images to make sure the high-dose volume is tightly wrapping the HRCTV and not spilling into normal tissue.
That's the clean, reproducible script we need. Now let's explore the implications. If that cumulative rectal dose was approaching 75 gray EQD2, what specific chronic complication are we most worried about, and what's the histology of that injury?
We are most worried about late radiation proctitis. Clinically, that means chronic bleeding, tenesmus, pain, potentially even a stricture.
And histologically?
Histologically, that late injury is characterized by progressive obliterative endarteritis, which leads to chronic ischemia. This ischemia damages the mucosal barrier, you get ulceration, and then the development of fragile telangiectasias that bleed very easily, often months or even years later. Exceeding 75 gray significantly raises the risk and severity of this.
Okay. Now for the violation twist. Same 7 gray plan, but after reconstruction, a recalculation shows the rectum D2CC is now 7.5 gray. That's unacceptable.
Why acceptable?
State the 3-step correction ladder you would use to fix this, and state the steps in order of preference.
Okay, I recognize a rectal D2CC of 7.5 gray is above our action threshold. I will immediately employ the 3-step correction ladder, moving sequentially from easiest to most invasive.
Step 1.
Step 1, physical correction. This is the first, fastest, and most powerful thing to do. I would stop planning, take the patient back into the OR, and reassess the physical setup. I'd substantially augment the posterior vaginal packing, making it denser, adding more gauze, specifically targeting the space between the posterior ovoid and the anterior rectal wall.
The goal being?
The goal is to physically increase the separation, leveraging that inverse square law to dramatically cut the rectal dose without even touching the plan. I mean, also consider a rectal retractor if we have one.
And if that's not enough?
Step 2, dosimetric correction. If the physical fix is unsuccessful or if the packing is already maxed out, I'd re-optimize the source dwell times in the planning software. This means reducing dwell time in the posterior ovoids and the lower tandem, and shifting that dose contribution superiorly or laterally, trying to pull the high-dose contour off the rectum.
And if that still fails?
Step 3, procedural correction. This is the conversion. If both physical and dosimetric fixes fail, I have to change the procedure. I would convert the plan to a hybrid intracavitary and interstitial approach by adding selective posterior needles. These needles can effectively pull the high dose points away from the rectal wall, delivering the dose conformally from a safer angle.
Physical, then dosimetric, then procedural. Perfect. In the context of that dosimetric correction, step 2, if you reduce the dwell time posteriorly to save the rectum, what's the immediate trade-off you absolutely must check?
The immediate trade-off is the risk of creating a new cold spot, of underdosing the posterior part of the HRCTV. By protecting the rectum, we risk dropping our D90 coverage below the target. So any dosimetric correction has to be immediately followed by a complete recheck of the HRCTV D90. If that D90 drops, we are forced to move to step 3.
Excellent. Let's move into our final block, complications and troubleshooting.
Okay.
During a tandem insertion on a patient who's had prior EBRT, you suddenly feel a significant loss of resistance while sounding. Fluoroscopy confirms your suspicion, a uterine perforation.
Right.
What is your immediate 5-step course of action?
Patient safety is the absolute priority. I'd execute a 5-step plan immediately.
Walk me through it.
1, stop and remove. Immediately stop the promoter and gently remove the tandem. Do not try to reinsert. 2, assess hemodynamics. Immediately check the patient's vitals. Look for any signs of hemorrhage, shock, or instability.
3,
medical management. Give antibiotics per protocol and start fluid resuscitation if necessary. 4, inform and document. Inform the patient and family, document the event thoroughly, and involve gynecology or IR if there's significant bleeding or instability.
and 5.
5, abort. The implant must be aborted for the day. For the reattempt, which would be maybe 7 to 10 days later, the technique has to change. I would use continuous transabdominal or transvaginal ultrasound guidance for the entire sounding and insertion, and I'd be much gentler.
It's good. Safety outranks schedule, and using imaging on the next attempt is key. Now, late complications.
Okay.
2 years after completing chemoradiation and brachytherapy for her stage 2B cervix, a 58-year-old returns. She's reporting intermittent painful rectal bleeding.
Hematochezia.
Yes, give me the essential differential diagnosis and the complete workup you would order.
Okay, the differential is primarily between two things: local recurrence of her cervical cancer versus late radiation proctitis. And we have to treat this as malignancy until it's proven otherwise.
So what's the workup?
It has to be comprehensive. 1, a thorough history and physical, including a careful rectovaginal exam to feel for any nodularity or masses.
Okay.
2, endoscopy, a flexible sigmoidoscopy or colonoscopy. We need to visualize the area. We're looking for the classic signs of proctitis, like telangiectasias, but crucially, we must biopsy any suspicious lesions or ulcers to definitively rule out malignancy.
And what else?
3, restaging imaging. This is mandatory. It includes a pelvic MRI for local anatomy and a PET CT scan to evaluate for local, regional, and distant recurrence.
And if the workup confirms it's just chronic proctitis, first and second line treatments.
If we've excluded recurrence, management is a step ladder. First line is medical: high-fiber diet, stool softeners, and topical anti-inflammatories like sucralfate enemas or mesalamine suppositories.
And as that fails?
Second line for refractory bleeding is endoscopic intervention. I'd refer her for argon plasma coagulation, or APC. It uses focused heat to ablate the bleeding telangiectasias, and it often works very well.
Great. Never label it proctitis without ruling out recurrence first. Last couple of questions on logistics.
Okay.
You realize a patient's overall treatment time is drifting past that critical 8-week deadline. How do you counsel her? And what practical steps do you take to fix the schedule?
I would counsel her by explaining clearly that the time prolongation is associated with a compromise in local control and increased risk of recurrence. I'd emphasize we need to prioritize finishing treatment now to preserve her chance of cure.
And practically?
Practically, I'd implement 2 steps. 1, accelerate brachytherapy. I'd immediately compress the HDR schedule to a twice-weekly cadence. 2, minimize gaps. I'd personally coordinate with scheduling and physics to secure protected slots, avoid any non-essential delays, and get any missed fractions back on the schedule ASAP.
Final question. Your patient is on a DOAC rivaroxaban for atrial fibrillation. How do you manage her anticoagulation around the brachytherapy implant procedure?
This requires clear, multidisciplinary coordination and documentation.
Step by step.
1, coordination. I talked directly with her cardiologist to make an individualized plan based on her thromboembolic risk. 2, holding the DOAC. For a high-risk procedure like this, it must be held. Rivaroxaban is typically held for 48 hours beforehand. 3, bridging. I would only consider bridging with low molecular weight heparin if she's very high thrombotic risk. Usually we try to avoid it.
And during the procedure itself?
4, procedural mitigation. I'd minimize needle passes if it's an interstitial implant, ensure good hemostasis, and schedule her early in the day for post-op observation. We typically restart the DOAC 24 hours later once we confirm hemostasis is stable.
Meticulous coordination, clear documentation. That's the key. Okay, that completes our mock oral session on GYN brachytherapy. We've gone from physics and dose constraints all the way to complex escalation and complication management.
That was comprehensive.
My final advice is this. You have to rehearse these structured answers and procedural scripts aloud until they are second nature. Board performance rewards crisp structure, clear thinking, and most importantly, demonstrating a patient-first safety protocol.
Thank you. This focused preparation, especially the deep dive into that correction ladder and the imaging roles, it provides the exact structure needed for performing under pressure.
Our pleasure. To complete more practice oral boards and access specialized study materials, visit radoncSmartLearn.com. And please subscribe to Rad Onc Smart Review for our next episode in the GYN Cancer Series. Thanks for tuning in.